Let me introduce Stefan Kemp, who's a full professor at Amsterdam's University Medical Center. I mean, the great thing about newborn screening is that we now identify kids early, as we all know, which is a godsend. However, you're also finding mutations that we don't know what they mean. And this is where Stefan will educate us.
Thank you, Amber. Good morning. So I promised to give an update on the gray zone, which is, of course, a project that started with ALD Connect. And I realized that it also started when the last time ALD Connect was... Actually, the gray zone project started when ALD Connect was the last time in Washington, and the only time in Washington, in 2017. So, let's see. Yeah. So these are my disclosures. I have really nothing to disclose. Except that the project is funded by the Virginia Tooman Foundation and ALD Connect. Okay, so if you talk about population screening, this is really offers a huge benefit for picking up people at risk for a conditioning, and then you can follow these individuals up and treat them in time. But this is a quote from Sir Mir Gray from the NIH in the UK, and it says that all screening programs do harm, some do good as well, and of these, some do more good than harm at reasonable cost. It basically comes down to there's a balance. And I'll go into that a little further, because population screening programs, in addition to identifying at-risk individuals, mass screening also will result in false positive results, broadening the clinical spectrum, because you screen you screen everybody, so you will also find late onset and mild cases. Uncertainty, when the test results cannot be considered completely normal or within the disease range. And this is actually what is the gray zone. And the identification of variants of uncertain significance. So I realized that saying a variant of uncertain significance is it's a finding in a genetic report, but what does it really mean? It comes down to something in the DNA, and if we talk about ALD, so this accounts for any condition. So if we specific this for ALD, it's a genetic variant that has never been reported in a clinically affected patient. And for ALD, there will be a patient that either has adrenal dysfunction, myelopathy, or cerebral ALD. It's often a missense variant, and a missense variant means that one building block of the protein is altered. And there's a little cartoon here at the bottom. This is a piece of DNA, and this codes for a protein. And amino acids, they have a 3-letter codon, but they also have a 1-letter codon. And so this protein says, I have a cat. So if now one of these building blocks is changed, we can have a different protein. And now we have another animal. Now we have a rat. And this is just caused by one nucleotide in the protein, so one piece of DNA in the building block. You get another building block in the protein, and you get a protein with a different function. Doesn't mean that this causes disease, but this is actually the basis of evolution. Not that it's one changed in evolution made a cat change into a rat, but this is just an example. So this is important to understand what a variant of uncertain significance is and what a missense variant is. Another concept that's really important, that I realized at 5 this morning, that I changed my slides again. Luckily I was allowed to. Because I often hear screen positive and elevated. People say, I'm elevated. And I thought, how can I explain what elevated is? And I think the simplest concept is, think of a building. So we have a building with many floors. And here we have the control level. So the bottom floors are the control level in any screening. And then we do population screening and we find something that is elevated or screen positive. So this is a positive finding in the screening, and it means that the DNA test and I bet you will find a missense variant. Because the missense variant causes a change in the protein, and the change in the protein causes the screening to be elevated. But this is not really meaningful, because what's missing here is where's the disease range. And so we really need to know the disease range. And so that's shown here. So depending on where the disease range is, the screen positive result can be in the disease range, or at the lower end of the disease range, or it can even be below the disease range. It's still elevated. It's a screen positive. This will mean that somebody is referred to the clinic and being followed up. But it's still possible that this individual will never become symptomatic or have the disease. And yeah, it's not by accident that the stories in between are colored gray, because this is the gray zone. And we need to find out, we need to set up a test in which we can define what the outcome means. Because there's some facts about ALD newborn screening. So I want to say before, screening is really important. It provides newborns with follow-up programs and timely initiation of treatment. But we also have to look at the other side of screening, the downside of screening, because there is a balance. So in the current situation, there are too many variants of uncertain significance being identified. We wrote a paper in which we did a calculation, but just looking at the reports from states that are published. And if you then count, you see that there are 2 or 3 times too many variants of uncertain significance being identified. So there's also a lack of harmonization between states and countries. The control levels, not the disease level, but the control levels are different in any state or any screening program. And of course, in our ideal situation, they should all be the same. Everybody should have the same screening algorithm or cutoffs. Of course, and this is really important, this is for any screening program. If either you talk about breast cancer, prostate cancer, any other metabolic screening test, there needs to be monitoring for the screening success. So, because what is the balance between true positives and false positives? And this is also referred to as the positive predictive value. And ideally it should be 100. But in many screening programs, it's not 100. Sometimes it's even 20%. So there's also no centralized program for dealing with variants of uncertain significance. And I also realized that in 2017, when we were in Washington, we also introduced women with ALD, because until that time, women were referred to as carriers. And if somebody is not familiar with the disease hears that somebody is a carrier, it means that you are a carrier for the disease. And in general, that doesn't mean that you become clinically symptomatic. Well, for ALD, it's clear that women with ALD will develop symptoms. So then we said we should not call them carriers, but we should call them women with ALD. So now I want to make another point, because I think that a person with a VAS is not yet a patient. So let's not call these individuals a patient, but an individual with a VAS. When somebody becomes symptomatic, or we know that the variant is pathogenic, yeah, then we can talk about the patient, but that this individual can still be somebody with no disease, as long as we have not defined it. So if we look at ClinVar, and ClinVar is a fantastic registry in which many genetic tests are reported from any testing, so also for ALD. And if we then look at the number of variants of uncertain significance that are reported in ALD, we see that there is a rise in the gray, how do you call the thing? The gray line. And that parallels the expansion of newborn screening. So at the moment in ClinVar, 46% of the variants, the missense variants, are classified as a variant of uncertain significance. And I was thinking about this, and this has to do with the fact that many different labs and companies perform genetic testing. And some of them are listed here, because you can just look at ClinVar who deposits the information, and these companies. And then the question is, if this is done in a clinically in a clinical lab where doctors give samples to the testing, there's the connection between the clinical status of the patient and doing the test. If you send a piece of a swab to a company and somebody does genetic testing, there's a disconnection between the information. So the question is, who classifies the variant in that company? Is there an expert review panel? We don't know. Or is it automatic algorithms? How is the variant classified? And on ground of what evidence? For me, I think this is a big black box. There's lack of transparency in the decision-making process. There's also proprietary algorithms and databases. And this is not proven, but I think that from a commercial standpoint, it's easier, and liability, it's easier to say that you don't know than you definitely say this is benign or pathogenic. In case you're wrong, you may be in trouble as a company. So if we now go back to the ClinVar data, there are 1,374 missense variants deposited in ClinVar. And these can be classified as benign, likely benign, variants of uncertain significance, likely pathogenic, or pathogenic. And this whole gray area here, that means that 629 cases, a report was sent to a family or a physician that following newborn screening, the result was unclear. Luckily for ALD, and this is quite unique, for many other diseases don't have this, we have an ABCD1 variant registry in ALD diagnostics. And we started this when I was still at Kennedy Krieger together with Professor Hugo Moser. This is actually just me, but a little younger. Because it was clear at that time already that there were so many different mutations identified in patients. Because then everything we got was from patients. Because there was no newborn screening, there was no pre-symptomatic screening. And at one moment I said to Dr. Moser, would it be not a good idea to put this on the internet? Which was also still a long time ago. And he said, Stefan, I think it's a very good idea. I support you. And so then we started the database in 1999. And I think it's really informative and helpful, especially also for newborn screening. So back to ClinVar. If I look at ClinVar, and this is again the same pie chart on the left with the 629 deposits by many different labs and companies, and I just parallel this with the ALD database. You can all do the same thing that I did here. And I look at all these variants and the classification, and I compare that with the information in the ABCD1 variant database. I can reclassify many of these variants, because on the right pie chart is the identical data, but then you see that the 629 variants of uncertain significance, many of them, almost 200, are now gone. They either went to the orange, the red, or the green pieces of pie. So I could reclassify many of these variants by just looking at the data that is out there. So back to newborn screening. So in case there is a known pathogenic being identified, it's clear. This individual needs to go into surveillance with MRI and treatment in time. And if there's a variant of uncertain significance, this individual will undergo the same process. But we don't know if this individual has ALD, or has a risk of developing ALD, or maybe never will develop ALD. But still they have to undergo the same procedure. And I think this is really where we can make a difference. And this is the Gray Zone project. Because here, I've shown this last year, family following a newborn screening, a test result comes back and it says a variant of uncertain significance was identified in the ABCD1 gene. And now what? So families and doctors are left in this position. And this is why we started the Gray Zone project. And we can build up on the work that Jorik presented yesterday, in which we look at lipids and C26 lyso-PC. And for now we see that there's a correlation with disease severity. And just to a little show off here, this is our laboratory in our core facility Metabolomics in Amsterdam. And these are all mass specs that you see over there. In the back, it's the diagnostic part. And on this side, it's the research machines. I have no idea how they work. If you want to know anything about these machines, you have to ask Jorik. I just know what we can do with it, and then I have to ask Jorik. I have to convince him. It doesn't take a lot of time. So can we do this? And then Jorik does his magic, and then we get really nice data. So the work that Jorik presented yesterday, this is the same data set. So we have controls, and they're plotted here on the left in green. And this is, now we look at the C26 lyso-PC. So this is the same biomarker that is used in newborn screening. In Amsterdam, we use this also for when Mark would send in a sample, can you confirm this is ALD? Then we do the same test. We moved away from plasma variant chain fatty acids, and we decided no matter what your age, we will look at C26 lyso-PC. So in green are the controls, in blue are all the clinically affected ALD patients in dark blue. But then also what Joy showed yesterday and what Mark also talked about, there's a group of males over the age of 50. They don't have adrenal involvement and they don't have cerebral involvement. They only have spinal cord involvement. And those are the light blue dots you see over there. And then in dark red, you see all the ALD patients with cerebral ALD. And here you see that there's a difference in the C26 lyso-PC between these two groups. Here are 53 gray zone samples that we have looked at since 2018. And you see that they're all clustered together. Some are in the ALD range, some are below the ALD range. We also know the genotypes because those are variants of interest significance, so we can also look at the genotypes, and they are shown here. So we looked at, sorry I didn't count, 26 different amino acid variants. And if we then look at the C26 lyso-PC levels, we see that some are green, some are still gray, and some are blue. So, and the blue they are in the LD range, the green ones are in the normal range, and the gray ones are sitting in between. So these variants in green, they are likely benign. I won't say benign, I will say likely benign, because I'm not a doctor, so I'm not making any clinical decision. I just give you the data, and it's up to the family, of course, and the doctor to decide what to do with it. I think what we can do in the gray zone is just help, give extra information, and here provide the stores in the building where the disease range is, so the floors. So the ones on the blue are likely pathogenic. Doesn't mean that they will cause ALD, but they're likely pathogenic. And of course, yeah, then we still have the ones in the middle, and they're either ALD, they're no ALD, or they're late onset ALD. But for now, they are a VUS. And for that, it's really important to have as many samples from as many individuals as possible, because what we can also do here is look at the age of the males in which these variants were identified. So there are variants in which there are grandfathers of 70 or 80 years old. They have this variant and they have no phenotype at all. And you can say, okay, of course there's always statistics and chances, but if we have 6, 7 or 8 grandfathers of 70 and 80 years old, they have the same variant as their grandson, and they have no clinical signs or symptoms, then it's very unlikely that this variant will cause cerebral ALD. Or, yeah, so maybe it is a late onset variant. I don't know, future will tell us. But in order to get that data, same as what Eric showed, you have to look at a lot of data. And in a consistent manner. So there's also the reason why we want to do this test in Amsterdam, because we have, since 2019, we are doing this. So we have an enormous amount of data. So, the first results of the Gray Zone project is that we analyzed C26 lyso-PC in samples from 53 individuals with a VUS. And these represent 26 different ABCD1 variants. So before, they were all VUSs, And now by looking at this information, from the 26, 12 are likely benign, 6 are likely pathogenic, and 8 are still of us. But we move forward from a large gray pie to additional information. And I really have to do a big shout out to people who are really, really important. One is not looking at me now, but hi Kelly. Because what is really unique in the Grey Zone project is that with the great help of Kelly and with Troy, that we are now able to provide this service for technically for the whole world. Because it's on my next slide. When we started with skin biopsies. We did this test in fibroblasts, and then we moved away. Then we moved to plasma, but plasma you need to send on dry ice, and it has to arrive in Amsterdam in 2 or 3 days, because otherwise the dry ice is gone, and the sample needs to be frozen. And unluckily, last year, several packages that were sent from different places in the world to Amsterdam, they did not arrive in time. Some arrived after 6 weeks or 7 weeks. Well, I'm not going to pick up that sample anymore. It's just completely lost. But it also means that you have to take another blood sample from an individual. And sometimes these individuals live far away from hospitals, or it's not easy to get. It sounds very simple, get a blood draw, but in real life it's more difficult. So we moved to blood spots. So maybe I should now go to my next slide. And then I can go back. Because in 2020, when we published the initial results on the basis that that Amsterdam moved from plasma variant transfusions to plasma C20 lysis PC, this is a very important graph from the paper, because here we look at the C26 level in dry blood spots and in plasma taken from the same sample, and we see a very straight line. With an R-square of 0.97. It means that either you take a blood spot or you take plasma, you will get the same C26 lysis PC. And what it comes down to is that you don't need to do this in plasma. You can now do it in dry blood spots. And dry blood spots you can just send by regular mail. So it's cheaper. And well, and if it takes 6 weeks, okay, it takes another 6 weeks to get the result, but the blood spot is still there. Yeah, so we from all over the world we are receiving samples, and it's now, since we moved to dry blood spots, it's really picking up pace. And then again I'm looking at Kelly, because what she did is well, mind blowing. So if a family or a doctor reaches out, can I participate in the Grey Zone? Well, they can email Kelly or me, and then we say yes. And then Kelly sends out this whole package, or kit, if you call it. And it includes explanation about the Grey Zone. So why are we doing this? There's an informed consent, because I really would like to have the genetic information and the C20 lysis PC, because with that information I can make those plots. There are GOT3 cards or newborn screening cards. There's also a protocol how to make blood spots. Because it's and examples of bad and good blood spots. And so it's not that difficult, but you just need to do how to do it, which is like swirling the tube and then pipetting a few drops on a newborn screening card. That's about it. And then you can proceed by making plasma that you can store locally. Oh yeah, and it has an address label, a prepaid address label, so that by FedEx it is sent for free to Amsterdam. So getting the blood spot, that's on the cost of the individuals who want to participate. But sending the sample to Amsterdam is free of cost. And the diagnostic test, so this is really a diagnostic test in Amsterdam. It's also covered by the Grey Zone project. And then we send back the results. I will report the value of the C26 lysis PC. I will let you know what our normal range is. But I also say, from a research perspective, from the paper that was discussed yesterday, this is our LD range. So now with this information, you have the building with the information you need to know, and then it's up to the receiving party what to do with it, how to interpret it, and how to follow up with it. Yeah, I would say send in samples and there's no limit. And even if it is not a variant of uncertainty, the third variant of us, but it's a missense variant, I also would like to have it. Because what we also see is that missense variants for which we know they're pathogenic, there's a correlation with the C26 lyse-PC. So, yeah, I also want to have those. So that's my acknowledgement slides, and yeah, here it is. If you want to participate, email us and request a kit. And I really want to acknowledge ALD Connect and the Virginia 2min Foundation. Thank you.
Thank you for that great presentation and the great work. Any questions for Stefan?
I am around, so...
Yeah. Okay.
Are you looking for everyone to request a kit that feels that they would like to, or is there specific people that you're looking?
Yeah, if it's a frame shift or a nonsense, so a variant in which we know there's no protein, you don't have to do it. Technically, if you know it's a missense variant and it's already registered as pathogenic, technically it's not necessary. But if you want to participate in the research study in which we can pursue all the studies that York is doing, in which we're going to limit correlate the missense variant to the C26 lyse-PC, so that's a research project. Yeah, please send it in. And it's really important to tell. So if there's a family and there's a child and there are 30 uncles and they all have the same variant, send them in, because the more numbers we have, the more data we have, the more power we have to make to say something meaningless, no, meaningful, meaningful.
Stefan, a quick question. How are you reporting, back over here, how are you reporting your data back into ClinVar, and how is that process? How are we improving the baseline there?
Yeah, that's a good question. Julie asked me that also. Huh, Julie? I'm not. And I think I don't have to, because we have the ABCD1 variant registry, and that's where I deposit it. It's always taking me a lot of time, and I personally don't have time to try to cover in ClinVar, but I have heard that there are some people at Kennedy Krieger who are interested in doing that, and they know how to do it. Hi, Julie?
Okay. So we probably have time for another question. One came in from online. Are you looking for newborns, adults, females, everybody?
Females, we can, yeah, sometimes you only have a female. We know the C26 lyse-PC is better than the plasma variant chain variation, because they have false positives and false negatives. C26 lyse-PC does it much better. So if there's only one female, yeah, then we do it. But the data is not conclusive, unless it's in the disease range. What was the rest?
And newborns, adults.
Oh, thank you for asking that. Newborns. So what I didn't show is that C26 lyse-PC in blood spots at birth is higher than later on. So after birth, the red blood cell count drops in the first 3-4 months. Troy, yeah, first couple of weeks. So and since C26 lyse-PC in blood spots is mainly sitting in red blood cell membranes, you can imagine that if there are less red blood cells, the level drop. So if a newborn, we always say, well, wait till they're at 8 to 5 months, because then the level is flat.
So basically, just to answer the question, anybody 5 months or older, you want their blood. Okay.
No, well, we can do the blood.
Yeah. Not to say you're a vampire.
Yeah, I wanted to say so. Yep.
So my question is, for those of us who know that ALD is in our family, because my son died, and obviously I am the female, not carrier, but symptomatic woman, you want a blood sample or you do not? Because I already know that I have C26.
Yeah, that would just be for the research project, but it's, yeah.
But is it beneficial to you?
if it's a missense variant, and we can look at the level of sheet-run ELISA PC in the mill. Yeah, that's it's always good for long for projects going where we technically start now.
Thank you, Stefan.